All right, so we're going to be going over Chapter 15, Medical Overview. Patients who need EMS assistance generally is either going to be medical or trauma. Today we're going to be talking primarily about the medical part, the illnesses or conditions caused by different diseases. There are 11 types of medical emergencies that we are going to be responding to. Respiratory emergencies, anything where there's trouble breathing, either they're having trouble getting air in or there's a problem with oxygen getting transferred to the cells. And these are caused by asthma, emphysema, or chronic bronchitis. These are just some of the respiratory emergencies. Then we have cardiovascular emergencies, which is going to be dealing with your MIs, which is your heart attacks or congestive heart failure conditions. Neurological emergencies involving the brain, that's your seizures, your stroke, and syncope. Syncope is just basically a fainting situation for no reason, and they recover from it. Gastrointestinal conditions, the appendicitis, diverticulitis, pancreatitis, and many other conditions. We have the urological emergencies dealing with kidney stones, bladder infections, the endocrine systems, most commonly caused by complication of diabetes, and the hematological emergencies that result from either sickle cell anemia or blood clotting disorders, your hemophiliac patients. Your immunological emergencies involved with the body systems that respond to foreign substance that gets into the body, and that's usually your anaphylactic patients. Toxicology, which deals with substance abuse, food, plant, or chemical poisonings. Then we have your behavioral emergencies and the gynecological emergencies that involve the female reproductive organs. So similar to the assessment of the trauma patient, with the trauma patient you assess the mechanism of injury, the MOI. With the medical patient we're going to be addressing the nature of illness, what is causing the illness. So we're going to concentrate on the signs and symptoms and their chief complaint. We're going to establish an accurate medical history of the patient. We're going to use the dispatched information, what the call was that came in, what they reported, what dispatch is telling us, and then what we observe once we get on scene. The thing to remember is do not get locked into a preconceived idea of the patient's condition. So in other words, don't form blinders. Just because a dispatch tells you one thing, don't just fix your concentration on that. Observe the patient and treat the patient. Assessment may be difficult with uncooperative or hostile patients. Sometimes the patients just aren't getting along. They're just not able to report accurately what's going on. So we have to maintain a professional, calm, non-judgmental demeanor, refrain from labeling patients, and a frequent caller may have different complaints at this time. So as far as labeling patients, maybe you have a patient you've gone to 10, 15 times in that month for the same problem. Each time you go on that call, you have to treat the patient as if it's their first call. We're going to do a good scene size up, make sure the scene is safe for you to be there. Use your standard precautionary measures, your gloves, goggles, and masks. Determine the number of patients and whether you're going to need assistance or not. Either a lift assist carrying them downstairs, or you may need ALS for the presenting conditions. The nature of illness is what is causing the illness. It's there like an MOI, the mechanism of injury, to increase your index of suspicion, to give you a direction as to how I'm going to treat this patient. We're going to develop a general impression. This is going to be a rapid examination of the patient. So this examination is as you're walking up to the patient, what do you observe? Are they acknowledging your presence? Are they communicating with you? How are they posturing in their general appearance? It's going to be able to give you a quick reference as to their mental status and their breathing ability. So we're going to assess the airway and breathing in conscious patients. If they're able to talk to you, they're breathing on their own, they are considered to have what they call a patent airway. We're going to check respiratory rate, rhythm, and quality. We're going to look and listen to their chest rise and fall. We're going to listen to the lung sounds so we can determine if it's a respiratory problem by listening to lung sounds, the different sounds. will be able to give us an idea of what type of illness they're dealing with. Consider applying oxygen to the patient if they're having a respiratory problem. Not all patients need oxygen. For the unconscious patient, make sure to open the airway using the proper techniques, and we had discussed that in Chapter 11. So oxygen to the patients, if they're in shock, if they're having difficulty breathing, if they have a low oxygen saturations. But with that low oxygen saturations, as we had discussed earlier in other chapters, you would treat the patient before you treat that number. When you put the pulse ox on, you're getting a low number. Make sure that low number is coinciding with the patient's conditions. Don't just treat that number. The devices that we're going to use, as we had discussed in Chapter 11, is your OPA, your NPA, and your BVM, as far as assisting them with their ventilations. Okay, circulation in the conscious patient, we're going to check their radial pulse, because by checking the radial pulse in the conscious patients, you have that space, that personal space when they're entering, instead of just going to their neck and checking the carotid pulse. We're also going to check their skin condition, or skin vitals. We're going to be checking color, temperature, and condition. So for the unconscious patient, just as in your trauma patient that's unresponsive, you have that golden standard. You have that golden 1 hour, which gives us that platinum 10 minutes on scene. That is the time of onset to the time they get the definitive care is going to decide how well they're going to recover from this. Okay, transport decision. You're going to have to make your transport decisions to, can I stay on scene and spend some time asking questions, or do I have to rapidly package up this patient and let's get transporting? On the history taken, we get to determine what the problem is or what may be causing the problem. We have to gather proper information through the past medical history, which is sample history, or the present illness using the OPQRST. For an unconscious patient, survey the scene for medications, containers, or medical devices. They could have medical alert bracelets that are on their wrist or around their ankles. You may have a medical card on their nightstand or in their wallet that's going to give you a history of their illness. Record any allergies, medical conditions, and medications that are present at this time. Some patients take numerous medications. So when we notify the hospital, either bring the medications with you or write them all down, because the medical problem that they're having right now may be a confliction between the medications they're taking. So secondary assessment may occur on scene or en route to the emergency department. So once we've done our primary, we've done our history taken, we've done our initial treatment, we're going to package up the patient, get him into the ambulance, and head out to the hospital. Now during this transport, we'll be doing a head-to-toe exam, looking for any other conditions that we may have missed in the primary assessment, treat any other conditions that we find. Then we'll repeat assessment of the airway, breathing, circulation. We'll repeat our vital signs and any interventions that we did on the way. So if the patient is stable, we'll do this every 15 minutes. If they're unstable, we'll do it every 5 minutes. And the thing that trumps both the 5 and 15 minute time frame is that change in the patient's condition. If I just did an assessment of this patient and all of a sudden they go unresponsive, we're going to start all over again, head to toe, and do the same process. We're going to do a physical exam, like I said, head to toe, neck closely, check the abdomen, the legs, the arms, the back, all the way down. Now, if the patient is conscious, I can just ask them questions about these areas. If they're unresponsive, this will be a complete hands-on head-to-toe exam. We're going to do our vital signs, assess pulse for the rate, quality, and rhythm. We'll identify our respirations, rate, rhythm, and quality. This under quality is where we're going to be doing the pulse oximetry, where we're going to be checking for oxygen saturation. We're going to obtain a blood pressure, do our skin vitals, color, temperature, and condition, and then check in the pupils to see if the pupils are pearl or if there's any action from the pupils. We perform once the assessment is performed, we're going to treat any conditions that we find. If need be, we'll call ALS for backup. Now, when we call for ALS backup, If we're ready to transport, we're just going to get up and go. And ALS will meet us en route to the hospital. We're not going to sit there and wait for them. And then we're going to document any developed changes in our patient's condition. So most medical emergencies require a level of treatment beyond the level of pre-hospital care. So we get on scene, we do a full assessment, do our initial treatment, package up the patient, and start our transport. As far as cardiac arrest goes, if we're doing CPR, we're going to stay on scene for the first 10 minutes doing CPR with our AED. Once we have that completed, we'll package the patient up, continue transport with CPR in progress. Hopefully ALS will join up with us. They'll put the monitor on and take over from that point. Okay, scene time. We can spend a little bit more time on scene with our medical patients than we do with our trauma patients. The reason why is most of the medical patients are conscious. They're talking to us, they're giving us a report, so that's going to take a little bit more time. Where a trauma patient, their injuries are obvious. We don't have to go searching for them. We can treat them right away, splint, do whatever we have to do, and start our transport. Now, if you decide that this patient needs a rapid transport based on how they're presenting, then you would load them up, get them into the truck, start doing your treatment and your interventions in the ambulance as you're transporting to the hospital, and ALS is en route. Your transport mode, life-threatening conditions, you're going to use lights and sirens, of course. So any condition where the patient is beyond your skill level or you don't have the proper equipment to take care of the patient, that's going to be a true emergency. That's going to be lights and sirens. But generally, all your non-life-threatening conditions is considered non-emergent, and you should not be transporting to the hospital with lights and sirens. Let's say we have an asthmatic. You get to the call, they're an asthmatic, they use their inhaler, you give them a treatment with the nebulizer, and their breathing is much better, but you're still having some wheezing, so you're going to transport them to the hospital for follow-up care. If they're breathing properly and their vital signs are stable, there's no need to go lights and sirens racing to the hospital. And that's on the protocol, Mass OMS protocols, routine care 1.0. There's no emergency, no lights and siren. If there is an emergency, then we use the lights and sirens to the hospital. All right, so we have the ground unit, which is your ambulances, your regular ambulance. Then we have the air unit, which is your med flights. That would be taken over from that point. All right, so deciding which facility are we going to go to. Generally, we go to the most appropriate hospital. And the appropriate hospital is based on the patient's condition. If this is a patient with a cardiac problem and they meet a certain criteria, we would be going to the hospital that has a cath lab. If this is an asthmatic, then we could be going to the emergency room. So based on the patient's condition and how they're presenting, we'll decide as to which facility would be most appropriate for them. If a patient is in your local town and you have a couple of hospitals in the general area and the patient has a medical condition and they tell you they want to go to hospital X, but the hospital you normally go to is closer, but their medical records and their doctors are at that further hospital, you can take that extra trip as long as the patient is stable to that hospital so they get better care. Not that they're going to get better care, but they're known there and their medical records are there. General assessment principles, approach like any other medical patient. How would you know to do otherwise? If you approach the patient, what's the scene like? Is the scene safe? Are there a lot of folks on scene that you may have to clear the room? How is the patient presenting? Every case is different, so you're going to have to step up, be the leader, and clear the scene and start assessing the patient. Perform a good scene size up and gather the patient's history using the OPQRST mnemonic that we've already gone over. Okay, general assessment principles, obtain a sample history. Sample history is getting information on their past medical history, allergies, medications, past pertinent medical history, what did they have to eat and what was going on when this all started. Ask them if they've traveled outside of the country recently. That may be an indicator of what is causing the problem. General management principles: focus on any life-threatening conditions that identify their primary assessment. Be empathetic, place the patient in a position of comfort, and use your standard precautionary measures: your gloves, your mask, and your goggles. An epidemic: this is new cases of disease in the human population substantially exceeded what is expected, where a pandemic is a disease outbreak that occurs on a global scale. So we're going to talk about some of the other illnesses that we didn't mention here, but these are more infections. Those are the chronic medical conditions comprise the immune systems, and then in the very young and the very old, so your influenza, your basic flu. Transmitted directly by direct contact with nasal secretions, aerosol droplets from coughing and sneezing by infected people. Infected people. Now here you're going to have to wear your mask, your gloves, and your goggles. And the reason for it, if you have someone who has a very productive cough, they got the flu and they're coughing and sneezing, they're spraying water molecules in the air, which you can breathe in and now become infected with that. So you're going to have to wear your mask, your goggles, and your gloves. The goggles are going to protect your eyes because they can get onto the eye, into your tear ducts, and get infected that way. If the patient is coughing very aggressively, even bringing phlegm up, you can put a mask on them. Generally, it's going to be your non-rebreather mask, or you can just put a regular surgical mask to give that extra protection. So for these diseases that can be passed through the respiratory, always wear your PPE, like I just said, gloves, eye protection, and your HEPA mask, your N95 mask, and place a surgical mask on the patient. As far as you as the provider, make sure you get your flu shots each year. If you're not going to be getting a flu shot, most ambulance companies are going to require that you wear a mask from the time you get on the company's property. So basically, once you get in the ambulance, you got to wear that mask all day until you're off duty. Common viruses strains carried by humans, the herpes complex, symptomatic infections cause varicels that appear on the lips and the genitals, can cause more serious illnesses in susceptible patients. The primary mode of infection is through close personal contact. HIV, EMTs face a risk of exposure. There's no vaccine yet to protect you from this. AIDS can still be fatal. However, with treatment, patients can expect a normal lifespan. HIV is a virus that causes AIDS. AIDS is a syndrome that affects the immune system. It's not easily transmitted. Here you have to, usually it's blood to body fluids, so blood to blood or body fluids contact exchange. So here, most likely it's going to be your needle sticks or IV drug use or unprotected sexual contact. Many patients with HIV show no symptoms. However, if they tell you they have AIDS, most of the patients will tell you that they're HIV and not to help protect, because they don't want you to get infected. So make sure on all your patients you're wearing gloves, mask, and goggles. I want to do that one over. Okay. So HIV infection, many patients with IV show no symptoms. However, always wear the proper type of gloves. Take care of in handling the disposal of needles and cover any open wounds. If you think a patient's blood or secretions may have entered your system, you have to do your unprotected exposure form, notify your supervisor. The form will be completed, sent to the hospital. If that patient does have a disease, a blood disease that you may have been infected by or could have been infected by, they'll fill it out and then they'll start the treatment process for you. Hepatitis, inflammation of the liver. Infection refers to an invasion or multiplication of bacteria or viruses within the body, while inflammation is the body's protective response against infection. Now, hepatitis B can be just as dangerous as HIV, and the reason why is because the hepatitis B virus can live outside of the body for a good 45 days. So if you have a wound, an open wound, and say you have someone who has hepatitis B, and they've bled on the stretcher. You clean, you change the sheets, you clean the mattress, you wipe it down, but you didn't get the bottom part of the rails of the ambulance. 2 weeks later, you're taking the ambulance out, you have a cut on your hand, you're in the shop, you're taking the ambulance out just for general cleaning, and you don't have gloves on. That blood flakes off into that open wound. There is a good chance now that you can be contaminated with hepatitis B, and you won't even know it. You won't know it until you start getting sick. So anytime you're working around your equipment, you should always be wearing your gloves. Once you take your gloves off, thoroughly wash your hands for a good 20 seconds under moving water, running water. All your equipment should be thoroughly cleaned. If you go on a call and there's a lot of blood and body fluids and you can't do a thorough cleaning at the hospital, once you get back to base, you should take everything out and give everything a thorough cleaning wearing your gloves. Get your vaccinations, your Hep B vaccinations. It's required for all EMTs. It says recommended, but most of the companies, all of the ambulance companies out there, when they hire you, they're going to have you get the hepatitis B vaccination. So hepatitis B, cirrhosis and hepatitis B are going to affect your liver. And then this is on page, this is your chart 15-2. So in your book, I forget what pages right off the top of my mind, but you have hepatitis A, B, and C. Hepatitis A is spread through fecal matter. Hepatitis B and C are both spread through blood and body fluids through sexual contact or IV drug use. Inflammation of meningeal coverings of the brain, this is your meningitis. It can be treated in the ED with antibiotics. After treating the meningitis patient, contact your employer for your health representative. If you take care of a patient that has meningitis, even though you got your gloves on and you're wearing all your PPE, you still should make out an unprotected exposure form. You fill out exactly what happened. Even though you're wearing everything, just protect yourself from in future, just in case you did get contaminated. Tuberculosis, most infected patients are well most of the time. That's a disease that usually strikes the lungs, but it can spread to other parts of the body, but generally it's the lungs. This patient is going to have a very productive cough. So anytime you're dealing with a patient who has a very productive cough, you should be wearing your mask, your goggles, and your gloves. And you should be wearing your N95 mask. If the patient is really producing a lot of phlegm coming up, put a mask on the patient or put the non-rebreather mask on them. Even if you're using O2 or not, put the mask on. With tuberculosis, absolute protection from the tuberculosis does not exist. There's nothing that you can do pre-hand except for using good PPE and getting your test yearly. If you're working on the ambulance, you should be getting your PPD test on a yearly basis. Also, whooping cough, also called pertussis. It's mostly effective in younger kids, 6 years of age and younger. Symptoms include fever and a whoop type sound after they cough when they're inhaling. The best way to prevent exposure is to be vaccinated. Place a mask on the patient and yourself. You have MRSA, which is a bacterial type infection. It's resistant to antibiotics. It usually happens in the healthcare settings. So people that have long hospital stays or are in the hospital frequently are more exposed to this type of infection. For the healthcare provider, wearing your gloves, and every time you take your gloves off, thoroughly wash your hands. If you don't have soap and water available, every ambulance has the antibacterial solution. Rub it, rub it in your hands to help kill the bacteria. And then once you get to the hospital, thoroughly wash your hands. So, continuing MRSA, antibiotic therapy, prolonged hospital stays, a stay in intensive care unit or burn units, exposure to infected patients. These are the factors that create a high risk for it. You as the EMT should always be wearing your PPE whenever you're treating a patient. Gloves, mask, and goggles. We've gone through COVID. You still have a 2 to 14 day exposure window. When you're dealing with someone that tells you they have COVID, or if they just have flu-like symptoms, or they tell you they feel like they have a sinus infection, something along that line, you should be wearing your mask, your gloves, your goggles. Put your vents on in the ambulance to circulate the air around. The best way to protect yourself from this is distancing, but as EMTs we can't do that. So the second best would be wearing your PPE. And then once you're done, once you transfer the patient over, give your ambulance a thorough cleaning, spray the Lysol aerospray in the back, vent the back of the ambulance thoroughly, and wash your hands. The Mid-East Respiratory Syndrome, coronavirus, same thing as COVID. It's going to be distancing, but if you can't do that, of course, we're in the back of the ambulance, wearing your PPE. Put a mask on that patient. Do your transport. After that, thoroughly clean the back of your truck and turn on your vents to vent the air out. Ebola, also known as the hemorrhagic fever virus, broke on 2014. Incubation period is 6 to 12 days. Fatality rate can be as high as 70% if treated, if you're not being treated properly. But the treat here, it's going to be dehydration and potassium. So they're going to be, those patients are going to be needed to have IV fluids for hydration and potassium for the cardiac. Beware of travel of people who have traveled outside of the country and then they come back and all of a sudden start getting sick. With any situation that you're going to be faced with out there, make sure you're wearing your PPE. After that, you transfer the patient over, washing your hands thoroughly, and washing your equipment down. That's the best way to prevent any kind of exposure for you and to protect yourself and your partner. So travel medicine, important questions to ask. Where were you recently traveling? Did you receive any vaccinations before you went? Were you exposed to any infectious diseases? Is there anyone else in your travel party who was sick? What types of food did you eat? And what was your source of drinking water? So this is chapter 15, medical overview. So this will conclude chapter 15.